Hello everyone, I am myself Dr. Rajesh Gubba. I am the General Medicine Educator. So in this session, I will be discussing the very important topic, that is COPD, that is Chronic Obstructive Pulmonary Disease. So if you see the definition of the Chronic Obstructive Pulmonary Disease, first of all, as the word itself tells you, it is an obstructive lung disease. So if you take the disorders of the lung, they are being classified into restrictive lung diseases and as well as the obstructive lung diseases based on the pulmonary function test. And COPD, it is an obstructive lung disease. So in these patients, right, in these patients with the COPD, there is airflow limitation. Right? And it is a progressive disorder. Right? Usually progressive. And this COPD, it is associated with enhanced inflammatory response. Right? It is associated with enhanced inflammatory response, where this enhanced inflammatory response will be present in the airways and as well as the lungs. Okay, so this is the definition of the COPD, right? It is a disorder where you have airflow limitation and it is usually a progressive disorder and it is associated with an enhanced inflammatory response in the airways and as well as the lungs. And if you take the subtypes of the COPD, we have two important subtypes in COPD. Number one, chronic bronchitis. And another important subtype is emphysema. Right, so these are the two important subtypes of COPD. Now, if you take chronic bronchitis, it is a disorder where the individual will have cough with expectoration for cough with expectoration for 3 months and 2 consecutive years. Right, for 3 months and 2 consecutive years. That will be your chronic bronchitis. And the type of expectoration that you will have in these individuals will be mucoid expectoration. Right, mucoid expectoration. Whereas if you take this emphysema, see, the word emphysema means inflation. Right, the word emphysema means inflation or distension with air. Right, the word emphysema means inflation or distension with air. That is what you mean by this word emphysema. Now, let me tell you that this COPD, it is the disorder of the smaller airways. Right, so this is a very important multiple choice question, that it is the disorder of the smaller airways. Now, when you are using this word smaller airways, what exactly you mean by this word smaller airways? What is the definition of the smaller airways? Smaller airways are defined as non-cartilaginous airways. Right, they are defined as the non-cartilaginous airways. And what will be the internal diameter of this smaller airways? The internal diameter it is less than 2 mm. Okay, so that is what you mean by this word, the smaller airways. And where are these smaller airways located? These airways are located from approximately 8th generation. Right? They are located from approximately 8th generation. So if you take the respiratory tree, there are totally 23 generations. Okay, from 8th generation of the respiratory tree, you have this smaller airways. So these airways are located from approximately 8th generation of the airways down to the terminal bronchiole, right? That means what are the parts of the airways which are affected is the terminal bronchioles and as well as the respiratory bronchioles, right? So I'll discuss that in detail subsequently, but remember it is the disease of the smaller airways. So now what is the smaller airway? Definition I have said you. Now, what are the examples of the smaller airway diseases? It is not only COPD, right? There are many other disorders which constitutes the disorders of the smaller airways. So, smaller airway disease, the examples include COPD and asthma. Right? COPD and as well as asthma. These are the smaller airway diseases. Apart from that, we also have the other smaller airway diseases that includes hypersensitivity pneumonitis, and other important example is bronchiolitis and mineral dust pneumoconiosis. Right, mineral dust pneumoconiosis. So these are the examples of the smaller airway disease. Then followed by that, what are the risk factors for COPD? Right, our point of discussion now in this session is about the COPD. What are the risk factors for chronic obstructive pulmonary disease? So smoking is a very important risk factor. So please remember this mnemonic, that is smoke. Now the word S in the smoke stands for smoking, right? Stands for smoking. And how do you calculate this particular smoking? That is in the form of the pack years, right? That is in the form of pack years. So wherein, how do you calculate this pack years? See, these pack years are calculated as packs of cigarettes per day multiplied by the number of years. Okay, so packs of cigars per day multiplied by number of years. That is how you will calculate the pack years. Then the word M stands for mutation, right? The word M stands for mutation. And mutation of which particular gene? Mutation of SERPINA1 gene. Right, mutation of the SERPINA1 gene. Now this SERPINA1 gene, it will code for a protein that is called as alpha-1 antitrypsin. So whenever there is SERPINA1 gene mutation, right, that will lead to alpha-1 antitrypsin deficiency, and this will make the individual to develop the emphysema. Right, I'll discuss in detail about this alpha-1 antitrypsin and what will happen when there is deficiency. The word O stands for occupation. Right, the word O stands for occupation. So occupation in the sense where the individual has exposure to fumes and chemicals. right, where the individual has exposure to fumes and chemicals. So that is your O. And the word K is a combination. See, actually the word combination starts with C, but for remembering in the form of a mnemonic, I have just put it as K. So combination of asthma and smoking. So if the individual is having an underlying disease, asthma, and upon that the individual is also a smoker, then there is increased risk of development of COPD. The word E is environmental pollution. So this is also a risk factor for the development of COPD. Now, if you take this asthma, see, you have to remember one point. Asthma is also an obstructive lung disease, and it is also the disease of the airways. Then what is the difference between COPD and asthma? Let me tell you, COPD, it is a progressive disorder. Right, COPD, it is a progressive disease or a progressive disorder. Whereas, if you take the asthma, it is a reversible disorder or a reversible disease. Right, it is a reversible disease. That is what is your asthma. Okay, right. This is the difference between asthma and COPD. COPD, it is an irreversible disorder, whereas asthma, it is a reversible disease. Now, having discussed about the risk factors for COPD, let me discuss in detail about this alpha-1 antitrypsin. So, if you take this alpha-1 antitrypsin, what is the role of it in development of emphysema? Whenever there is deficiency of this alpha-1 antitrypsin, why there is development of emphysema? Let me discuss that in detail. So, lung is made up of the connective tissue. Right, lung is made up of the connective tissue, and this particular connective tissue of the lung, it is digested by the proteolytic enzyme protease. Right, it is digested by the proteolytic enzyme, the protease. Okay, and this protease, it is released from WBCs. Right, this protease, it is released from the WBCs. Okay, now this protease, which is the one which is responsible for the digestion of the connective tissue, it is prevented. So I'll just let me tell you, connective tissue of the lung is digested by your enzyme protease. Now we have a substance which is a protease inhibitor. Right, we have a substance which is a protease inhibitor, and that protease inhibitor, we call it as anti-protease. Right, this protease inhibitor, we call this as anti-protease. And what is that particular anti-protease? That is alpha-1 antitrypsin. Right, alpha-1 antitrypsin, that is your anti-protease. Okay, and that anti-protease is the one which will prevent the proteolytic digestion of the lung. Right, which will prevent the proteolytic digestion of the lung. Okay, so this will prevent the proteolytic digestion of the lung. So, for suppose if there is alpha-1 antitrypsin deficiency, when there is alpha-1 antitrypsin deficiency, that will result in the proteolytic digestion of the lung. Right, that will result in proteolytic digestion of the lung. And because of the proteolytic digestion of the lung, that will result in what is called as the development of emphysema. Right, that will result in what is called as development of emphysema. And remember, this particular alpha-1 antitrypsin deficiency, it is a genetic disorder which is inherited as an autosomal recessive pattern, right? Which is inherited as autosomal recessive pattern. Now, in these patients with the alpha-1 antitrypsin deficiency, what is the type of emphysema the individual develop? The individual develop what is called as pan-acinar emphysema. Now, what do you understand by this word pan-acinar emphysema? It is the entire acinus which is abnormally irreversibly dilated. That is what is called as the pan-acinar emphysema. I'll discuss about this in detail subsequently. And as such, this type of emphysema, it is rare, right? It is rare and occurs in young adults. Right, occurs in young adults. Now, what will be the manifestation of this pan-acinar emphysema? It manifests as the progressive dyspnea, right? It manifests as the progressive dyspnea and minimal cough. Okay, progressive dyspnea and as well as minimal cough. Now, what are the other conditions associated with the alpha-1 antitrypsin deficiency? The other conditions which are associated with alpha-1 antitrypsin deficiency include bronchitis, right? Number 2, hepatic cirrhosis. Number 3, vasculitis. And then panniculitis. Right? And then panniculitis. So these are the disorders associated with alpha-1 antitrypsin deficiency. That is bronchitis, hepatic cirrhosis, vasculitis and as well as the panniculitis. Now, so this is about the story of alpha-1 antitrypsin deficiency. Very simple, right? We have an enzyme called protease which is released by the WBCs. They will cause the proteolytic digestion. And your alpha-1 antitrypsin is the one which will act as an anti-protease. So whenever there is an alpha-1 antitrypsin deficiency, the protease will cause the digestion of the lung and that will make the individual to develop what is called as emphysema. And what are the other disorders associated with alpha-1 antitrypsin deficiency? Bronchitis, hepatic cirrhosis, panniculitis and as well as the vasculitis. Then, let me discuss the pathogenesis. So as such, like what did I tell you in the definition itself? Both of these subtypes, chronic bronchitis and as well as the emphysema, they occur as a result of an inflammatory process. Right? Both of them, they occur as a result of the inflammatory process. Okay? And this inflammatory process, it involves the airways and distal air spaces. Right, it involves the airways and distal air spaces. Now, actually, if you see the development of COPD, it's an inflammatory process. Why you have that inflammatory process in the distal airways and in the respiratory tree? That is because of increased activity of, right, that is because of increased activity of oxidants, right, increased activity of the oxidants combined with reduced activity of antioxidants. Right, combined with reduced activity of antioxidants. These have been implicated in the development of inflammation. Right, these have been implicated in the development of inflammation and subsequently the development of the chronic obstructive pulmonary disease. Now, where is the question of your oxidants and antioxidants have come? Right, particularly you take in patients who are smokers. See, the cigarette smoking is associated with a variety of abnormalities of the respiratory system. And all these abnormalities predispose to the development of the chronic bronchitis. Now, what are those inflammatory mediators of the cigarette smoking? Let me tell you. So basically, cigarette smoking, how does it predispose the individual to the development of chronic bronchitis? That is by the process of the inflammation, right? And how does the inflammation occurs? That is by inflammatory mediators. So this cigarette smoking, it produces the high concentration of, right, high concentration of oxygen free radicals. Right, high concentration of the oxygen free radicals. And these oxygen free radicals, they include reactive oxygen species. Right, these oxygen free radicals, they include the reactive oxygen species. And what are the examples of these reactive oxygen species? That includes superoxide, hydrogen peroxide, and hypochlorous acid. Right, reactive oxygen species include superoxide, hydrogen peroxide, and the hypochlorous acid. Now, these substances, they are responsible for tissue damage, right? They are responsible for tissue damage and activation of eosinophils and neutrophils. Right, activation of eosinophils and as well as the neutrophils. Now, there is inflammation now because of these oxygen free radicals, and this inflammatory response is initiated through the activation of the transcription factors, and this transcription factor is the nuclear factor Kb, right? Now, and one way by which the cigarette smoking will cause the inflammation of the airways is by release of your oxygen free radicals. Now, apart from that, cigarette smoke or cigarette smoking, it produces various oxidants and activated neutrophil damage alpha 1 antitrypsin. Okay, so this cigarette smoking also produces the various oxidants. And what does this various oxidants do? These various oxidants and as well as the activated neutrophils, they damage the alpha 1 antitrypsin. Right? They damage the alpha 1 antitrypsin. And this alpha 1 antitrypsin is the one which is required to prevent the degradation of elastin. So, this will prevent this will prevent the degradation of the elastin. Now, all these, that is one, release of your oxygen free radicals, and as well as the oxidants that will be causing damage to your alpha 1 antitrypsin, all these result in various changes seen in patients with chronic bronchitis and emphysema. Right, all these results in various changes seen in patients with chronic bronchitis and as well as the emphysema. Now, so whatever we have discussed now is the pathogenesis of the smoking. How does the smoking cause the development of COPD? Now, let me discuss the pathology of smoking. That is, in smokers, what exactly the change occurs? Number one, there will be sluggish ciliary movement, right? Sluggish ciliary movement. Number 2, there will be bronchoconstriction. Right? And this bronchoconstriction is through smooth muscle contraction. Right? Is through smooth muscle contraction. And third important pathology of smoking is hypertrophy and hyperplasia of mucus secreting glands. Right? Hypertrophy and hyperplasia of hypertrophy and hyperplasia of mucus secreting glands. So these are the pathological changes that will occur in smoking, and few more changes. There will be also inhibition of function of alveolar macrophages. Right? Inhibition of function of the alveolar macrophages. So this is about the pathology of smoking. These are the changes that will happen. And another important point that you need to know, particularly in patients with the chronic bronchitis, is about the Reid index. What is this Reid index? See, Reid index, it is the ratio of thickness of the submucosal glands. You see here, these are the mucus glands. So it is the ratio of thickness of submucosal glands right to that of bronchial wall. Right, to that of bronchial wall. That is being expressed as the Reid index. You see here, this is the mucus glands, submucosal glands, and this will be your entire bronchial wall. So ratio of thickness of submucosal glands to that of bronchial wall is nothing but your Reid index. And in a normal individual, how much is the Reid index? In a normal individual, the Reid index is 0.44 plus or minus 0.09. That is a normal Reid index. But in patients with chronic bronchitis, this particular Reid index is increased. And how much it will be? That is 0.52 plus or minus 0.08. Okay, so that will be the Reid index in patients with chronic bronchitis. Right? And another important point is, if the submucosal layer thickness is more than 50% of the bronchial wall, right? This is the submucosal layer. If the submucosal layer thickness is more than 50% of the bronchial wall thickness, it is highly suggestive of the chronic bronchitis. So please remember this. So if this submucosal thickness, if it is more than 50% of the bronchial wall, right, then it is suggestive, highly suggestive of chronic bronchitis. And please remember, higher is the Reid index, right, higher is the Reid index, more will be the symptoms. Right, higher is the Reid index, more will be the development of symptoms. That is what is the importance of the Reid index. Now, if you take the clinical manifestations in COPD, there are 3 cardinal features of COPD. That includes, number 1, dyspnea, right, where the individual will have difficulty in breathing. Number 2, development of chronic cough. right? Development of chronic cough. See, initially the cough is present only in the winter seasons, that we call it as winter cough, or we also call this as the smoker's cough, right? So initially it is present in the winter, so it is called as the winter's cough, right? Or it is also called smoker's cough, and this cough of chronic bronchitis is usually seen early in the morning. That is why it is also called as the morning cough. Okay, and this cough is associated with production of mucoid expectoration. Right, associated with the production of mucoid expectoration. So these are the three cardinal features of COPD: dyspnea, chronic cough, and as well as the sputum production. Now let me discuss in detail about the emphysema. Right, now first of all you should know the definition in detail about the emphysema. As such, emphysema, I said you, like distension of the airways. And if you take the exact definition considering to your respiratory tract, emphysema is a condition characterized by, right, characterized by abnormal, right, abnormal, right, permanent enlargement of permanent enlargement of the airways distal to the terminal bronchioles. Right, distal to the terminal bronchioles. So this is what is the definition of the emphysema. Right. So now, what are the structures which are present distal to the terminal bronchioles? Let me discuss. The structure which is distal to the terminal bronchiole, that we call it as acinus. Right, that we call it as acinus. And this, what is the important function of the acinus? The important function of the acinus is gas exchange. Right, the important function of the acinus is the gas exchange. Now, what are the structures which are present within the acinus? That includes respiratory bronchioles, right? Number 2, alveolar ducts and the alveoli. Okay, so this is what the acinus is made up of. Okay, now let me just show you in the image as well. Right, so this is the entire respiratory tree, right, which you have totally 23 generations. Out of this, distal to the terminal bronchiole, right, out of this, distal to the terminal bronchiole being affected in emphysema. And what are the structures which are present distal to the terminal bronchiole? That is respiratory bronchioles, then alveolar ducts, then the alveolar sac, and then the alveoli. These are the structures which are affected distal to the terminal bronchiole in patients with the emphysema, right? In patients with the emphysema. So now, emphysema is a condition characterized by abnormal permanent enlargement of spaces distal to the terminal bronchiole, and it is characterized by destruction of the gas exchange air spaces, that is respiratory bronchiole, alveolar duct, alveolar sac, and the alveoli. And this part of the lung we call it as acinus, which is required for the gaseous exchange. Now, because the gaseous exchange zone is destroyed, right, because the gaseous exchange zone is destroyed. Because the gaseous exchange zone is destroyed, the individual will have impairment of the gaseous exchange, and that will result in the development of dyspnea. Right, that will result in the development of dyspnea. Right, next. Now, this particular emphysema, it is classified based on the anatomical site where you have the accumulation of the air, where you have the presence of the air pockets. So that includes, number 1, pulmonary emphysema. Number 2, we have mediastinal emphysema. And number 3, we have subcutaneous emphysema. So these are the 3 types of emphysema based on the anatomical site of the individual. Now, out of which what we are interested here about the pulmonary emphysema. And clinical features just now we have discussed. Right, it is characterized by gradual onset dyspnea. Right, and this gradual onset dyspnea, it is progressive. Right, it is progressive. And these patients with emphysema, they are considered as the pink puffers. The other name of emphysema is pink puffers. And why are they called as pink puffers? Because there is lack of cyanosis in these individuals. Right, because there is lack of cyanosis in these individuals. And because there is dyspnea, right, because there is dyspnea, there is usage of the accessory muscles of respiration. Right, there is usage of the accessory muscles of respiration, and there will be a pursed lip breathing. Right, there will be a pursed lip breathing. So this will be the clinical features in patients with emphysema. Now, regarding this dyspnea, let me discuss the grading of dyspnea. So the grading of dyspnea is being given by Modified Medical Research Council scale for dyspnea. So accordingly, we classify the dyspnea into the 5 grades, that is grade 0, 1, 2, 3 and then 4th. You take grade 0. Grade 0 is that where the individual gets breathless only on strenuous exercise, that is shortness of breath, on strenuous exercise. Whereas grade 1, the individual gets breathless when hurrying on the level ground. Right, hurrying on the level ground. That is grade 1. Grade 2 is that where, so grade 1, the individual will have dyspnea on hurrying on a level ground or walking up a slight hill. That is your grade 1 dyspnea. Grade 2 dyspnea is that these individuals, they walk slower than people of the same age. Right, walks slower than people of same age on a level ground. And these individuals, they walk slower than people of same age because of breathlessness. or these patients with grade 2 dyspnea have to stop for breath while walking at his own pace on the level, right? While walking at his own pace on the level. That is your grade 2 dyspnea. Grade 3 dyspnea is that the individual stops for breath after walking 100 meters. Right? Stops for breath after walking, right? After walking 100 meters or after a few minutes on a level ground. That is your grade 3 dyspnea. Grade 4 dyspnea is that where the individual is too breathless to leave the house. Where the individual is too breathless to leave the house, right? Or the individual will have breathlessness even while dressing or undressing. That will be your grade 4 dyspnea, right? So this is about the grades of dyspnea according to your Modified Medical Research Council scale for dyspnea. Let me tell you, this is respiratory onset dyspnea. For cardiovascular disease onset dyspnea, the scale what we use is the NYHA scale. Okay. Now, followed by that, you see the next question. Alpha-1 antitrypsin deficiency is associated with centriacinar emphysema, panacinar emphysema, irregular emphysema, paraseptal emphysema. The answer here is panacinar emphysema. Now, let me discuss the various subtypes of the emphysema. Right. The first one is the panacinar emphysema. See, so if you see this panacinar emphysema, panacinar emphysema is the disorder where the entire respiratory acinus it is abnormally dilated. That is respiratory bronchiole, alveolar duct, alveolar sac and alveoli, right? Everything is dilated. That is what is your panacinar emphysema. Okay, that is from the respiratory bronchiole to alveoli, everything is expanded. And this panacinar emphysema, it occurs more commonly in the lower lobes. Right, it occurs more commonly in the lower lobes, especially the basal segments. The basal segments of, right, especially the basal segments of the lower lobes. Okay, now let me just show you an image also of this panacinar emphysema. Yes, so in case of panacinar emphysema, it is the entire acinus which is abnormally dilated. And this panacinar emphysema, as already we have discussed, it is seen in patients with alpha-1 antitrypsin deficiency. Then followed by that, we have centriacinar emphysema. See, this is your centriacinar emphysema. So, what do you understand by this centriacinar emphysema? This is also called as the centrilobular emphysema. So, in case of the centriacinar emphysema, it is the respiratory bronchiole, that is the proximal and central part of the acinus is expanded, right? That is proximal and central part of acinus is abnormally dilated or it is expanded, whereas the distal part of the acinus, it remains unchanged. Right, the distal part of the acinus, it remains unchanged. And panacinar emphysema, we have discussed, lower lobes are affected, whereas centriacinar emphysema, it is mainly the upper lobes which are affected. Right, it is mainly the upper lobes which is affected. Okay, and next important type of emphysema, it is paraseptal emphysema. Right, let me discuss in detail about this paraseptal emphysema. So, paraseptal emphysema, it is a type of emphysema which involves the alveolar ducts and alveolar sac. Right, alveolar ducts and as well as the alveolar sacs. Right, and which part of the lung is affected? It is the peripheral part of the lung. Right, it is the peripheral part of the lung which is affected in the paraseptal emphysema. And this paraseptal emphysema, it may cause spontaneous pneumothorax. Right, this may cause spontaneous pneumothorax. That is what is your paraseptal emphysema. Now, another form of emphysema is the compensatory emphysema. See, compensatory emphysema, it is a condition where the normal lung tissue undergoes the hypertrophy. Right, the normal lung tissue, it undergoes the hypertrophy. That is what is your compensatory emphysema. So, and the normal lung tissue, it undergoes hypertrophy as a compensatory mechanism for an extensive damage to the other lung. Right, so the normal lung tissue, this undergoes hypertrophy. As a compensatory mechanism to extensive damage right, compensatory mechanism to extensive damage to the other lung. Right, that is what is your compensatory emphysema. Okay, now let me discuss the complications of emphysema now. Types of emphysema we have discussed: panacinar emphysema, paraseptal emphysema, centriacinar emphysema, and compensatory emphysema. Then let me discuss the complications of emphysema. Complications of emphysema, number one, the pulmonary bullae. Right, so what is this pulmonary bullae? These pulmonary bullae, they are inflated thin walled spaces. Right, inflated thin walled spaces. That is what is called as the pulmonary bullae. And this pulmonary bullae, if they rupture, that will make the individual to develop the pneumothorax. Right, that will make the individual to develop pneumothorax. Okay, and that too a spontaneous pneumothorax. And development of this spontaneous pneumothorax, it is mainly associated with subpleural bullae. Right, mainly associated with the subpleural bullae. For suppose, if there is presence of large bullae, right, if there is presence of large bullae, this can interfere with the pulmonary ventilation. Right, this can interfere with the pulmonary ventilation. That will be your pulmonary bullae. Whereas respiratory failure, if you see, in these patients with the emphysema, they will have respiratory failure. In early stages, they will have type 1 respiratory failure, which is characterized by, right, which is characterized by hypoxemia. And as the severity progresses, there will be development of type 2 respiratory failure, where you have hypoxemia and as well as the hypercapnia. That is what is your type 2 respiratory failure. And another point is, there is development of pulmonary hypertension and right heart failure. See, pulmonary hypertension and right heart failure, these are the late complications in emphysema. right? These are the late complications in emphysema. So these are the complications of emphysema that you have to remember. Now, let me just give you a table of differences between the chronic bronchitis and as well as the emphysema. So, if you see this table over here, chronic bronchitis, the age at which the individual has is around 40 to 50 years. Whereas emphysema, the age group which is commonly affected is 50 to 75 years. And what will be the clinical manifestations in case of chronic bronchitis? It is cough associated with the expectoration. Whereas in case of emphysema, it is the dyspnea which is being present. But there can be also a mild cough, right? In the later stages, there can be mild cough even in case of the emphysema. But whereas in chronic bronchitis, the cough is present in the early stages itself. Now, these patients with chronic bronchitis, they are more prone for the development of infection. Whereas emphysema, it is occasionally they are prone for infections. And respiratory insufficiency also, if you see, in patients with chronic bronchitis, they have repeated respiratory insufficiency. But in emphysema, the respiratory insufficiency is present only in the terminal stage. And cor pulmonale, this cor pulmonale, it is common in chronic bronchitis patient. Whereas cor pulmonale, it is rare or it is seen in the terminal stages in patients with emphysema. Then airway resistance, it is increased in patients with the chronic bronchitis, right? And in patients with the emphysema, the airway resistance is normal, right? The airway resistance is normal. And if you take the elastic recoil, in patients with chronic bronchitis, the elastic recoil is normal. Whereas in emphysema, the elastic recoil is low, right? The elastic recoil is low. And what about the chest radiograph? In patients with chronic bronchitis, they have prominent bronchovascular markings, right? I'll show you this X-ray. Whereas in emphysema, you have bilateral hyperinflation, right? I'll show you the X-ray of the chronic bronchitis and as well as emphysema both. And chronic bronchitis, these patients, they have cyanosis, right? And appearance wise, they are called as the blue bloaters. Whereas emphysematous patients, they have no cyanosis, right? And that is the reason why these individuals, they are called as the pink puffers, right? That is the reason why these individuals are called as pink puffers. That is in patients with the emphysema. Now, these are some differences between chronic bronchitis and as well as the emphysema. Now, let me tell you one of the very important complication secondary to this chronic bronchitis or the emphysema, that is secondary polycythemia. Why does this secondary polycythemia occurs? In both of them, or particularly if you take in patients with emphysema, these patients, they have hypoxemia. And secondary to this particular hypoxemia, it will stimulate the erythropoietin production from the kidney, right? Hypoxia is a stimulus for erythropoietin production. And this erythropoietin, which is being produced in excess quantity, that will be responsible for excessive erythropoiesis. Right? That will be responsible for excessive erythropoiesis. That is what you will have in emphysema. And even to certain extent in chronic bronchitis as well. Now, secondary to this particular hypoxemia, the individual will also develop pulmonary hypertension. Right? The individual will also develop pulmonary hypertension, and subsequently there can be development of right ventricular failure as well. Right? Subsequently, there will be development of right ventricular failure as well. And that we call it as the cor pulmonale. So, I'll discuss in detail about this cor pulmonale. But before that, if you see one of the very important question, all of the following statements about emphysema are true except. Shortness of breath is a characteristic presenting symptom. Diffusion rate of carbon monoxide is reduced. Restrictive pattern of pulmonary function test is seen. Long-term bronchodilator therapy does not improve the lung infection. And in emphysema, because the acinus is affected, which is an air exchange part of the respiratory tree, there is impaired exchange of gases and shortness of breath is a characteristic presenting symptom. And diffusion rate of carbon monoxide is reduced because the air exchange zone, that is acinus, is affected. And they will not have restrictive pattern on pulmonary function test. What they have is the obstructive pattern. Right, what they have is the obstructive pattern. And long-term bronchodilator therapy does not improve the lung function. It's an irreversible disorder. It's a progressive disorder. So long-term bronchodilator therapy does not improve the lung function, but symptomatically the individual will feel better with the long-term bronchodilator therapy, but it will not improve the lung function. So that is a true statement. So which is the incorrect statement here? It is the option C. Now let me discuss in detail about the cor pulmonale. What is the definition of the cor pulmonale? What are the causes for cor pulmonale? And how do you treat this cor pulmonale? So, if you take the definition of the cor pulmonale, it is the disorder where you have enlargement of the right ventricle. Right, where you have the enlargement of the right ventricle. And this enlargement of the right ventricle, it is associated with or without right ventricular failure. Right, it is associated with or without right ventricular failure. And this right ventricular failure, it is secondary to lung disease, right, it is secondary to lung disease or due to disease of the pulmonary circulation. Right, due to disease of the pulmonary circulation. That is what is your cor pulmonale. And in these patients, they have, for suppose, if there is development of right ventricular failure, there will be features of right ventricular failure. Right, there will be features of right ventricular failure, and that includes raised JVP, tender hepatomegaly, and pedal edema. Okay, so these are the features of the right ventricular failure. Now, you should know what are the causes for cor pulmonale, right? Common causes for cor pulmonale. See, the common causes for cor pulmonale, if you see, most common cause for acute cor pulmonale, that will be your pulmonary thromboembolism. And most common cause for chronic cor pulmonale, that will be your severe COPD. These are the causes for your cor pulmonale. And we also have some less frequent causes for the development of cor pulmonale. They include, number one, pneumoconiosis. Right, so pneumoconiosis is the disorder where the individual has, or where it is characterized by an occupational lung disease. Then the other less frequent causes includes pulmonary fibrosis, then third, kyphoscoliosis, fourth, primary pulmonary hypertension, and next, obesity hypoventilation syndrome, that is Pickwickian syndrome. Right, so Pickwickian syndrome, it is the obesity hypoventilation syndrome. It is a condition in which severely overweight people, they fail to breathe rapidly enough or deeply enough. So because of this obesity hypoventilation syndrome, these individuals, they have low oxygen levels and high carbon dioxide levels. That is what you will have in Pickwickian syndrome. Then chronic severe asthma. Right, chronic severe asthma. So these are all the less frequent causes for the development of the cor pulmonale. So if you see the treatment of the cor pulmonale, oxygen supplementation is the one which is very important in the treatment of cor pulmonale. And this oxygen supplementation will cause the pulmonary artery dilatation, right? And as there is pulmonary artery dilatation, there will be decrease in the pulmonary artery pressure. And not only that, this oxygen supplementation will also correct the acidemia, right? Will also correct the acidemia. And the other treatment options are bed rest, right? Number 2, salt restriction. Next, diuretics may add some benefit. Right, diuretics, they may add some benefit. Now, apart from that, in these patients with the cor pulmonale, they are more prone for the development of the cardiac arrhythmias. Right, they are more prone for the development of the cardiac arrhythmias. And particularly, the type of cardiac arrhythmia that you will have is MAT, that is multifocal atrial tachycardia. So what do you understand by this word multifocal atrial tachycardia? Multifocal atrial tachycardia is the disorder where you have the heart rate of more than 100 per minute and you have 3 different morphological P waves. Right, 3 different morphological P waves. That is what you understand by this term, that is multifocal atrial tachycardia. And these patients, they respond to aggressive treatment of COPD itself, or you need to give calcium channel blockers, that is diltiazem or verapamil can be given if the individual develops the multifocal atrial tachycardia. Now, the other forms of the arrhythmias like atrial fibrillation can also be seen in these patients with the cor pulmonale, and there can be also the atrial flutter. So the atrial fibrillation and as well as atrial flutter, these require DC cardioversion. Right, these patients, they require DC cardioversion after the initiation of the antiarrhythmic therapy. And another very important point is that in patients with COPD, as a part of treatment, we give theophylline, which is a phosphodiesterase inhibitor. But when the individual develops cardiac arrhythmias, theophylline should not be initiated in acute settings. Right, this theophylline, which is a phosphodiesterase inhibitor, should not be given in acute settings of your cardiac arrhythmias. Now, in these patients with the cor pulmonale, definitely what is the presentation here? There is dyspnea. In patients with COPD, it is dyspnea. So, for suppose if the dyspnea has progressed to a state of development of respiratory failure, right? If the dyspnea has progressed to a state of the respiratory failure, then tracheal intubation and mechanical ventilation. Right, tracheal intubation and mechanical ventilation, these are necessary if the individual progress to the development of your respiratory failure. So, but initially the patient can be tried with NIV, that is non-invasive ventilator, right? That is non-invasive positive pressure ventilation. And this non-invasive positive pressure ventilation, it is delivered through a tight fitting face mask, right? It is delivered through tight fitting face mask. But in spite of NIV, if the individual is like desaturating, that is the point when we need to do the tracheal intubation and the patient has to be put on the mechanical ventilator. And the other treatment options in COPD patients is antibiotics, which we will discuss that in detail in the treatment of COPD. But here I just want to confine myself for the treatment of the cor pulmonale itself. And if you see one question related to cor pulmonale, all of the following are radiological features of chronic cor pulmonale except curly B lines, prominent lower lobe vessels, pleural effusion, cardiomegaly. So you have the curly B lines, that is secondary to your interstitial edema. Pleural effusion can be there, right? This interstitial edema will further progress to alveolar edema. Alveolar edema will further progress to pleural effusion. And there will be also cardiomegaly in patients with the chronic cor pulmonale. But the prominent lower lobe vessels, they are not seen in patients with the chronic cor pulmonale. So what they have is prominent upper lobe vessels, right? They have prominent upper lobe vessels. So this is what you will see in patients with the cor pulmonale. Then you take the pathogenesis of complications. See, we have discussed multiple complications in patients with the COPD. Why does those complications occur? Let me discuss the pathogenesis. So in patients with the COPD, there is mismatch of ventilation and as well as perfusion. And that is the reason why there will be hypoxia and as well as the hypercapnia. And because of this hypoxia and hypercapnia, the individual will develop what is called as type 2 respiratory failure. And second important thing is, there is increase in the carbon dioxide levels, right? There is increase in carbon dioxide levels, and that will make the individual to develop the carbon dioxide narcosis. And because of the carbon dioxide narcosis, there will be pulmonary artery vasoconstriction, and that will result in the pulmonary hypertension. And once there is pulmonary hypertension, there is increased afterload on the right ventricle. Right, there is increased afterload on the right ventricle, and that will progress to the development of right ventricular hypertrophy and then right ventricular failure, and there can be functional tricuspid regurgitation. That is what you will have in patients with the chronic hypoxia and hypercarbia. So these will be the complications secondary to your hypoxia and hypercarbia. And secondary to your hypoxia, there is increased erythropoietin production from the kidney, and that will make the individual to have increased erythropoiesis, and that will cause secondary polycythemia. And because of this secondary polycythemia, so what is happening here? There is increased RBC with hemoglobin, but there is impaired oxygenation here. So the quantity of reduced hemoglobin will be increased. So as the quantity of the reduced hemoglobin is being increased, that will progress the individual to develop cyanosis, where there is bluish discoloration of the mucous membrane. And because of hypoxia, there is also desaturation of the hemoglobin. So these are the pathogenesis of the complications that you will come across in patients with the COPD. Then you take the laboratory features in patients with COPD, right? That is particularly in emphysema. If you take pulmonary function test, it show you an obstructive pattern, right? And what will be the features of the obstructive pattern? Where your FEV1 by FVC will be reduced, right? FEV1 by FVC will be reduced. And not only that, in patients with emphysema, diffusion capacity of the lung for carbon monoxide, diffusion capacity of the lung for carbon monoxide, that is also reduced. DLCO is also reduced. Then you take the chest X-ray. Chest X-ray is a very important first line investigation that will help you to differentiate whether it is an emphysema or whether it is a chronic bronchitis. See, this is a chest x-ray of patients with the emphysema, right? What will be that chest x-ray picture in patients with emphysema? Number one, hyperinflated lung fields. Right, hyperinflated lung fields. And these hyperinflated lung fields you have on both the sides, that is bilateral. And then second important, these lung fields which are hyperinflated, they will overlap the heart. And that is the reason why if you see the heart in the chest x-ray, it appears as the vertical heart. Right, it appears as the vertical heart, or it is called as the tubular heart. And third important, these hyperinflated lung fields, they will compress the diaphragm. So that we call it as low set diaphragm. Right, that we call it as low set diaphragm. And there will be also presence of the bulla, that is blebs. And next important thing, if you take the intercostal spaces, right, intercostal spaces, they are widened. Right, they are widened. So that will be the features of the COPD. Right, that is emphysema, the chest x-ray of the emphysema. Then you take in patients with the chronic bronchitis. In chronic bronchitis, what is that you will observe is there will be increased bronchovascular markings. Right, there will be increased bronchovascular markings. So how will you say that there is increased bronchovascular markings? Right, if you see the vessels, right, they are occupying more than 2/3 of the lung. Right, the bronchovascular markings, they are occupying more than 2/3 of the lung. That is the reason why we call it as, that is the point that tells you that there is increased bronchovascular markings. So this will be the chest x-ray picture in patients with the emphysema. But what is the definitive test? That is the CT scan, which is the definitive test. Right, and polysomnography. In which group of individual polysomnography is important? That is mainly in patients with obesity. Okay, right, these patients, they develop obstructive sleep apnea. For them, the polysomnography sleep study is very important. And another very important investigation is ABG, that is arterial blood gas analysis. See, arterial blood gas analysis will tell you what type of respiratory failure the individual is suffering with. You take in patients with chronic bronchitis. In patients with chronic bronchitis, they have hypoxia and hypercapnia. So this hypoxia and as well as hypercapnia, this will present as the respiratory acidosis. Right, so once there is respiratory acidosis, the individual will present with altered sensorium. The individual will present with decreased consciousness. The individual may go into a state of coma also in this respiratory acidosis. So ABG will tell you that there is presence of respiratory acidosis in chronic bronchitis. That is the importance of ABG. Whereas you take in patients with the emphysema. In patients with emphysema, in early stages, the individual will have type 1 respiratory failure. Right, and ABG will show you the presence of only hypoxemia, and not only hypoxemia, there can be decreased carbon dioxide as well. Why there will be decreased carbon dioxide? That is because in patients with emphysema, there is impaired gaseous exchange, due to which there is hypoxia, and there will be increase in the respiratory rate. And this increased respiratory rate will cause the carbon dioxide washout, resulting in the hypocapnia. And the ABG, what does it show you here? This will show you the presence of the respiratory alkalosis. Right, this will show you the presence of the respiratory alkalosis. So that is what you will see in patients with emphysema. Right, so chronic bronchitis, type 2 respiratory failure. Emphysema, type 1 respiratory failure. So chronic bronchitis, you have type 2 respiratory failure. Right, emphysema, it is type 1 respiratory failure. Next, another important investigation is alpha-1 antitrypsin levels. Alpha-1 antitrypsin levels, right, they are measured mainly in young patients presenting with COPD. Right, measured in young patients presenting with COPD. Because young patients, why do they present with COPD? One of the very important risk factor is the gene mutation, that is hereditary disorder. And what is the gene mutation? That is SERPINA1 gene mutation. So once there is SERPINA1 gene mutation, there will be reduced levels of alpha-1 antitrypsin, and I have explained already the pathogenesis, why there will be development of COPD. So, and not only young patients, even there is family history of COPD also, you should do the alpha-1 antitrypsin. Now, after having discussed about the investigations in patients with COPD, let me tell you, based on the severity of the COPD, and how do you assess the severity of COPD? That is based on the pulmonary function test. Accordingly, we have a criteria that is called as GOLD criteria. So, GOLD criteria, what does this tells you? It is Global Initiative for Obstructive Lung Disease. Right, Global Initiative for Obstructive Lung Disease. That is what is called as your GOLD criteria. See, according to this particular GOLD criteria, we classify the COPD into the following stages. That is stage 1, stage 2, stage 3, and then stage 4. So if you take stage 1, it is mild COPD, where your FEV1, see, how do we assess the severity of COPD in the GOLD criteria? That is mainly based on FEV1 percentage, that is forced expiratory volume at the end of first second. In all the stages, your FEV1 by FVC will be reduced. Right, in all the stages of your COPD, FEV1 by FVC will be less than 0.7. There is no doubt in that. But how do you classify that into 1, 2, 3, 4? That is based on the FEV1 percentage. See, in mild, the FEV1 percentage, it is more than or equal to 80% of the predicted value. Whereas in stage 2, this is moderate forms of COPD. In stage 2, the FEV1 percentage, right, here it is around 50 to 79% of the predicted value. Right, 50 to 79% of the predicted value. Whereas stage 3, this is the severe form of the COPD. And here if you see the FEV1 value, it is around 30 to 49% of the predicted value. Right, 30 to 49% of the predicted value. Whereas stage 4, it is very severe form of COPD, and here the FEV1, it is less than 30% of the predicted value. Right, so these are the stages of your COPD. And if you take the treatment also, in stage 1, if you supplement the short acting beta agonist that will be sufficient for the relief of the individual. Whereas in moderate COPD, you also need to add, right, along with the short-acting beta agonist, that is beta 2 agonist, you also need to add LABA, that is long-acting beta agonist, or you need to add the anticholinergic drugs. And what are those anticholinergic drugs and all, I will discuss in detail in the treatment part. Whereas you take in stage 3. In stage 3, you need to add inhaled corticosteroid. Right, you need to add the inhaled steroids. Whereas in stage 4, you need to add long-term oxygen, and if there is presence of the pulmonary bulla, you need to consider the bullectomy, that is you need to consider for the surgery. So this is about the gold criteria for your COPD.